Good day everyone. We are in Module 12 of Cardiorespiratory Pharmacology on non-steroidal anti-asthma agents. These module objectives are the following: to discuss the indications of non-steroidal anti-asthma agents, what are the available non-steroidal asthma agents, especially those that we find here in the Philippines, differentiate the specific non-steroidal anti-asthma agents, what are the available routes of administration, the mechanism of action, and the use of these non-steroidal anti-asthma agents in the treatment of asthma. For the past 2 years na my baby has had episodes ng reactive airway disease. Every time she gets confined sa hospital, pag uuwi na siya, pag na-discharge na kami, may nadadagdag sa meds niya. So aside from her usual treatment na nebulization, which includes your bronchodilators, meron siyang salbutamol, plus ipratropium, plus meron din siyang corticosteroids, which is your budesonide in nebules din. Laging may dinadagdag na Montelukast. So at first, powder form siya. That was last year. Yung brand niya is Sinclair. Hinahalo siya sa milk before siya, yung last milk niya before siya matulog, dun nilalagay. But recently, tablet na. Pero dinidikdik ba rin? Then hinahalo ulit sa milk. If meron na siyang mga treatments like this salbutamol, ipratropium, corticosteroids, ba't kailangan pang dagdagan ng Montelukast? In Module 11, we learned about corticosteroids like your budesonide and fluticasone, that they control inflammation. In real life, like in my baby's case, doctors still add another drug, your Montelukast. Both of them are anti-inflammatory, but they are two different drugs and they have different pathways of inflammation control. So yung Montelukast natin, as we speak today, know that it is not replacing steroids. It is targeting a different part of the inflammatory process. Specifically, for Montelukast, your leukotrienes. So instead of just suppressing inflammation broadly, we are now blocking a specific pathway. So today, in Module 12, we will understand why Montelukast is added, what makes it different from steroids, and how these multiple drugs work together in asthma control. You've seen this last Module 11, where we focus on corticosteroids, and we say that this is the main controller drugs that target inflammation, which is the root cause of asthma. Now we talk about Module 12. These are non-steroidal agents, but also target inflammation through different specific pathways. So, recap ulit tayo, your Module 6 and 7, these are for bronchospasm, although your Module 6 are your rescue drugs. Ang pang-treat ng root cause of your asthma is your Module 11 corticosteroids. And now we have also other anti-inflammatory drugs which are non-steroidal. So yan ang pag-uusapan natin today. This slide is from our Module 11, and I just want to pull it out again because there are parts here in the inflammation pathway ng asthma where our Module 12 drugs works. So, again, dito sa ating inflammation sa airway, we start with triggers. May allergen, may dust, may cold air. And this activates the mast cells. So, important yan. Tingnan natin yan. And these mast cells, they release chemicals like your histamine, ECFA, NCF, bradykinin, and lymphokines. And these chemicals cause yung sinasabi nating bronchoconstriction. Yung bronchoconstriction agad, hinihingal agad yung patient. That's why we give agad mga bronchodilators. Late phase pa, yung nafe-feel natin na mga meron ng mucus, hyperreactivity edema. And ito yung paulit-ulit yung asthma kahit na parang kahapon okay na kanina okay na, pero meron pa rin. This is how complex inflammation is, and we should know what parts of this pathway dapat ginagamit yung drugs. So let's locate that. Sabi natin last module 11 that simultaneous with the production of mast cells ng ating mediators is the phospholipid is converted to arachidonic acid by phospholipase A2. And this is the turning point. Meron tayong two pathways, the COX and the LOX again. The COX produces prostaglandins and the LOX produces leukotrienes. Nasabi din last module 11 that leukotrienes are one of the strongest causes of asthma inflammation. So, puntahan na natin yung important part dito pa lang sa ating second slide. Where do each drug sa ating module 12 acts? So, meron tayo nung start dito. Palitan natin yung kulay. We have mast cells stabilizers. So, cromolyn. Example, cromolyn. Dito pa lang sa simula, meron na tayong drug for that. And the cromolyn here stops the mast cell from releasing the chemical. So, wala na tayong, ayan, ni-stabilize siya. So, it prevents histamine, it prevents all these mediators. So, wala pang inflammation, pinipigilan na agad. We have also anti-leukotrienes. So, saan ba lumabas yung leukotrienes natin? Andito siya sa LOX. Dito naman, even if may inflammation na, we block the leukotrienes. So, there are two types dito sa ating anti-leukotrienes. Meron tayong Montelukast or Zafir-Lucas. They block the receptor. Si Xyluton naman blocks the production. So, walang mabubuong leukotriene. Again, there are two types of anti-leukotrienes. The one that first blocks the receptor and the other one is blocks the production. Last natin dito is the monoclonal antibody. So, meron pa, even before this mast cell natin, we are working with, wala dito pa sa ating diagram na ito. The IgE, it works by blocking itong IgE natin. So, walang activation ng mast cell. Parang pinatay mo yung mismong trigger. So, now you understand why even may steroid na, which works dun sa ating genes mismo. Remember yung 3 steps ng ating corticosteroids? It increases yung lipo, decreases yung ating troublemakers, yung dalawa, at saka it locks yung isa dito sa troublemakers. So, hindi mo makikita itong ginagawa ng steroids dito sa mismong inflammation of airway. So, makikita mo yan dito sa Module 12 kung saan gumagana yung mga drugs nila. So, even meron ng steroid, dinadagdagan pa natin ng other anti-inflammatory drugs. And these are not redundant. They are complementary. Ayan, this is also from our Module 11 slide where we discuss about the mechanism of action of corticosteroids. Yung tatlong ginagawa niya. But these ones are, nandun siya sa mismong cell at mismong gene expression ang ating tina-target. So you don't see what the steroids does sa mismong pathway ng ating asthma, inflammation. So, balikan natin yung tatlo dito. Ino-on niya yung anti-inflammatory, which is yung ating lipocortin. Ino-off niya yung ating inflammatory genes, yung NF-kappa B, tsaka yung AP1. And then, nilalock niya more yung ating NF-kappa B. So, it will not activate again. So, yun lang yun mismong ginagawa ng corticosteroids. Dun siya mismo sa root cause ng ating asthma, inflammation. This slide is just showing the one that we talked about kanina, yung ating cromolyn or mast cell stabilizers, anti-leukotrienes, and monoclonal antibodies. You have this sa inyong book, and these are under your controllers. Again, hindi siya mga relievers because they are not bronchodilators. They are anti-inflammatory drugs. So, they are for control, not for rescue or reliever. And this diagram here shows us kung saan yung ating IgE. Yung IgE natin is the one that activates the mast cells. Yung missing kanina dun sa ating diagram that we can find sa book natin. Now that we understand where these drugs work in the inflammation pathway, kailan naman natin sila ginagamit? So, ang pinaka-main use of your non-steroidal anti-asthma agent is as prophylactic management of mild persistent asthma. So, prophylactic means pang-prevent, hindi siya pang-rescue. So, again, yung slide natin kanina, these are controller drugs, not relievers. Hindi ito ginagamit kapag hinihingal na yung patient. These are used when the patient needs, parang yung sa steroids natin, it's more than twice a week na niya kailangan ng bronchodilator, meaning hindi na controlled ang asthma niya. This is what we call yung step 2 care ng asthma. So, we use it as alternative to steroids, just like your cromolyn and anti-leukotrienes. It can be used as alternative sa ating mga inhaled corticosteroids. Why alternative? Akala ko ba complementary sila, ma'am? Some patients cannot tolerate steroids or ayaw ng steroids or ayaw ng mga side effects ng steroids. Let's say yung immunosuppression. So, ayaw na nila yon. Next is, you use it in infants and children. Cromolyn is often used in infants and young children because of safety concerns with steroids. Just like what I shared earlier, sa baby ko, instead of increasing yung steroids niya, the doctors added two safer options like Montelukast. And finally, it's used in combination with ICS. Add-on to steroids. Yung anti-leukotrienes natin can be used with steroids to reduce yung steroid dose. So, instead of increasing the steroid, we add another drug targeting a different pathway. So, it's a combination therapy. So, that better yung control natin, parang synergistic, and lower ang steroid exposure. We again go back to the mechanisms of inflammation in asthma. We have a different figure from the past module, but in here we just highlight that again, asthma is an inflammatory disorder, and in this module, what we want to emphasize that we don't have in the previous module is that we have an allergic mechanism and a non-allergic mechanism for the inflammation in asthma. For the allergic stimuli, it triggers the IgE-mediated mast cell release of mediators of inflammation. And we have in here, it produces we need to remember, it activates the immune system and produces IgE antibodies, which are the ones that binds to the mast cell. And we know already at this point that mast cells release inflammatory mediators. What are those inflammatory mediators again? Your histamine, your cytokines, your leukotrienes. Yes, these are the same chemicals we talked about earlier. What are the non-allergic triggers? Itong mga non-allergic triggers. We have here yung cold air, exercise, smoke, pollution. So, not all asthma are allergic. So, kahit walang allergen, dito, it shows us na pwede pa rin maging asthma. And this brings us to the types of asthma, your extrinsic and intrinsic asthma. Extrinsic means X, nasa labas siya. It's triggered by external allergens such as dust, pollen, and food. This is the one that is your IgE mediated. Yes. For intrinsic asthma, this is the internal, meaning no clear allergy, walang sensitization. It's not triggered by a it's actually triggered by a non-specific stimuli. Walang allergen like these ones, pero may inflammation pa rin. And so regardless of type, either extrinsic or intrinsic asthma, the final result is still inflammation. The final result is still your bronchoconstriction, your mucosal swelling, and your mucus secretion. Ito yung dahilan kung bakit nahihirapan huminga ang patient natin. We follow this diagram step by step so that we know later where the drugs act on. So everything starts again and again with a trigger. So either this or this one. So for this trigger, this activates the T cells or T helper cells, specifically your T helper 2, TH2. And your TH2 releases, yan, your interleukin 4, 5, and GM-CSF. Yan. Dito. So, ito yung signal to start the allergic response. Now, your B cells here produce IgE bodies. IgE antibodies. So, your IgE attaches to the mast cells. And this is the sensitization stage. Now, when exposed again, these mast cells release mediators. Naglalabas sila ng mga mediators. And kilala na natin yung mga yan. Your histamine, your prostaglandins, your leukotrienes, your cytokines. Ito yung chemical bomb ng asthma because these mediators even recruit more cells. You recruit more cells, yung inyong eosinophils and your neutrophils. And these adhesion molecules help stick and enter the airway. So, more cells here, meaning more inflammation. Now, it sticks to your smooth muscles, to your VCAM1, and this part, sa mucus glands natin. So, there will be edema or swelling dito sa ating blood vessel leakage. Merong bronchoconstriction dito sa ating smooth muscles. Meron din siyang mga neural component ito sa acetylcholine natin and sa substance P for inflammation again. So, hindi lang siya immune, meron din siyang nerve involvement. And again, even without allergy, itong sulfur dioxide natin, cold air and fog, these can directly trigger the airway. Yeah. Now we look at the drugs for inflammation ng asthma that are not steroidal. So if you understand this table, kaya nyo na halos lahat ng exam questions sa Module 12. Let's start with the earliest point, yung ating mast cell stabilizer. This is your cromolyn. Cromolyn works before the inflammation even starts. Pinipigilan niya yung mast cell natin para hindi na siya mag-release ng inflammatory mediators. This is for prophylaxis. So, wala tayong bronchodilation dito. So, hindi ito binibigay kapag hinihingal na ang patient. Next is your anti-leukotrienes. Or anti-leukotrienes, meron tayong dalawa dyan. Your receptor blockers at yung iyong production inhibitor. For the receptor blockers, ang meron tayo dito is your Montelukast and Zafir-Lucas. So, as receptor blockers, binablock nila yung leukotriene receptors, specifically yung cis-LT1 natin. These drugs act after the mediators are produced. Because ang binablock na nga natin is your leukotriene pathway. So, hindi makakakabit yung leukotriene, walang effect. This is, sabi nga natin kanina, itong Montelukast, yung binigay kay baby. This is the most commonly used add-on therapy. Yan. This is why, also, you can give Montelukast even if may steroid na. Kasi nakalabas na yung ating leukotriene at binablock na lang natin yung pag-bind ni leukotriene sa receptors. We have another anti-leukotriene, which is a production inhibitor, your xyleuton. There's a slight difference because the xyleuton does not block the receptor, it blocks the production itself. So, no leukotriene made, no leukotriene effect. So, here, ang important na kailangan nating maalala dito is kailangan i-monitor yung liver ng patient. Now, we even go upstream sa ating monoclonal antibody, yung ating anti-IgE. Dalawa to, again, may monoclonal antibody na anti-IgE, may monoclonal antibody ng anti-leucan or eosinophil. So, anti-IgE natin is your omalizumab. It blocks IgE. So, it binds IgE so that walang mast cell activation. So, nakita nyo yun sa figure natin kanina na galing yung IgE from your B cells. So, and that will bind dun sa inyong mast cells. So, it binds to the IgE para hindi siya mag-bind sa mast cells natin. Meaning, wala talagang inflammatory cascade. And this is used for moderate to severe asthma. Usually, this is injectable. This is not the first line, but this is an advanced therapy kasi mismo mga antibody na yung mga binibigay. The last one is the monoclonal antibody, but it is an anti-interleucan or eosinophil. So, meaning, iba yung target niya dito sa first one. This one is IgE. This one is anti-interleucan or eosinophil. So, they reduce inflammation at the cellular level. Kapag meron na tayong severe asthma, when all other drugs fail, we give this one. So, again, si cromolyn, sa pinaka-start, prevents release. Si Montelukast natin blocks the receptor. Si xyleuton natin stops production of leukotriene. And for monoclonal, yung ating omalizumab, it blocks the trigger, which is your IgE. Same goals, different targets. So, if you ever get confused, you just ask yourself where the drug is acting. So, the earlier the drug acts, the more preventive it is. The later it acts, the more it controls ongoing inflammation. Tingnan ulit natin dito sa new figure natin where those drug acts. So, start natin dun sa cromolyn, which prevents mast cell degranulation. So, andito si mast cell natin. At ang mechanism of action natin is before release of mediators. Yan. You see yung IgE natin attached dito sa ating mast cell. So, ang mangyayari pag nag-attach siya doon, there will be degranulation and then mag-form ng histamine, leukotrienes, and cytokines. So, the cromolyn acts here. It stops the mast cell from releasing those mediators. So, pinipigilan niya yung explosion ng mast cell before pa maglabas ng inflammatory chemicals. Now, we go to the next drug natin, which is your Montelukast or Zafir-Lucas. So, after your leukotrienes are released, nandito, mga leukotrienes are released at the target tissues, your smooth muscles, your blood vessels, your mucus gland, yan, meron tayong mga cis-LT1 receptors. So, yung cis-LT1 receptors natin, those, kapag may nag-bind doon, it causes bronchoconstriction, edema, and mucus. So, this is where your Montelukast or Zafir-Lucas works. It blocks the leukotriene receptors from binding to the receptor. So, may leukotriene na produce na dito, yung leukotriene. Pero, walang effect kasi na-block yung receptor. Next, we go to your xyleuton. Another anti-leukotriene, but it inhibits your 5-lipooxygenase. Although the location is not shown here in this pathway, maalala nyo yung arachidonic acid pathway natin. And then this one is merong LOX and then COX. So, andyan siya sa pathway na yan. Even before your leukotriene, diba this one produces leukotrienes, this one produces prostaglandins. Even before your leukotrienes are formed, yan, the xyleuton acts here. It blocks yung enzyme that forms leukotriene. And that enzyme is your 5-LO, your 5-lipooxygenase enzyme. So, hindi pa nabubuo yung leukotrienes, nakat agad yung source. Nakat agad yung source. And next, we have the monoclonal antibodies. Your first one, the one that binds to IgE, your omalizumab. So, this is between your B cells and mast cell pathway. Dito rin siya sa part na to. So, your omalizumab binds to the free IgE. Di ba nag-form si beta cell ng B cell ng ating IgE? So, it prevents the attachment of the IgE sa mast cell. So, it blocks this part, yung attachment. So, walang trigger, walang mast cell activation. The last one natin dun sa table is your anti-interleukin or eosinophil natin. So, ang location niya is for your this T helper cell, yung ating interleukin 4, interleukin 5, yung sa eosinophils. So, yung T helper cell releases itong interleukin 4 and 5 for IgE production and eosinophil activation. So, these drugs act here. Okay? It blocks the interleukin pathways at yung inyong eosinophil activation or survival. So, pinapatay or pinipigil ang inflammatory cells mismo. When you send later on sa group chat natin, this checkpoint, you write checkpoint number 1 and then your answer. Okay, the first 3 to answer the checkpoints, meron silang additional 1 point for the recitation list natin. So, checkpoint number 1, arachidonic acid goes to 2 pathways, the COX pathway which produces blank and the LOX pathway which produces blank. So, again, when you send your answer, checkpoint number 1, and then you give the 2 emojis or icons dun sa ating group chat. For checkpoint number 2, you put again checkpoint number 2 and then you answer, give your 4 letters, yung pagkasunod-sunod nila. Hindi isa-isa, okay? Don't put cromolyn and then C and then Montelukast and A, mga ganon. It should be C, D, A, B, mga ganon. So, checkpoint number 2, match the drug to its action, cromolyn, Montelukast, xyleuton, and your omalizumab. Checkpoint number 3, tell me if it is a controller or not. So, pagkasunod-sunod ng mga emojis ang isa-send for checkpoint number 3. Cromolyn, leukotriene, biologics, beta-2 agonist. So, if it's controller, happy face. Kung hindi siya controller, it's the surprised face. Checkpoint number 4, where does each act? So yan, cromolyn, kung early ba or late. Montelukast, kung anong pathway. Xylitol, kung anong production. And omalizumab, kung ito ba ay upstream or downstream. So checkpoint number 4, pagkasunod-sunod no phases. For example, cromolyn, sasabihin nyo late. Montelukast, X pathway. Xylitol, blank production. Omalizumab, kung upstream siya or downstream. So, a while ago, we saw the diagram na mast cell ang pinakaunang nagre-release ng inflammatory mediators. So, ngayon ang tanong, what if we stop the mast cell from releasing anything? And that's where your cromolyn comes in. Your cromolyn sodium is a mast cell stabilizer. So, it's not a bronchodilator. It is a preventive anti-inflammatory drug. It prevents inflammation before it starts. So, going back to the pathway, your IgE binds to the mast cell degranulates and releases mediators. But with cromolyn, it blocks this mast cell degranulation. So, no degranulation, no mediator release, no inflammation. So, important detail here is that it requires pre-treatment. Wala na siyang effect once inflammation started. Remember, the inflammation is a cascade. So, kapag meron ng inflammation, wala nang use si cromolyn. This has no bronchodilation effect also. Meaning, hindi ito rescue drug. Kapag hinihingal na, hindi pwedeng cromolyn ang bibigay. So, pang-prevent lang ito. When is it used? So, cromolyn is used in mild asthma as alternative to your inhaled steroids, used for pediatric patients, used also for exercise-induced asthma and allergic rhinitis. It's normally given as a nebulizer or metered dose inhaler or as nasal spray. So, important is that this is used or must be taken regularly kasi prevention nga siya. It's not as needed. Hindi siya PRN. So, very little of this cromolyn is absorbed systemically. So, it is relatively safe, but meron pa rin tayong minimal side effects. So, ang meron dito dahil ang route of administration natin is through inhalation or intranasal. So, nagkakaroon ng cough, pwedeng throat irritation, and bad taste. Anong outcome nito sa real patients natin? So, cromolyn can help suppress actually cough in patients with ACE inhibitors. ACE inhibitors are given to those patients with hypertension. At ang common side effect ng ACE inhibitors natin is your cough. Ang mga ACE inhibitors examples, yung mga captopril, enalapril, if you know those hypertensive drugs. So, meron silang cough na side effect. And cromolyn can help suppress those cough because it reduces inflammatory mediators involved in cough reflex. Interestingly, your cromolyn may reduce sickling of RBCs. So, it has an anti-sickle cell effect. So, possibly, ginagawa ito ng cromolyn by blocking calcium-activated potassium channels. Sa asthma, syempre, pinaka-important natin, prophylactic lang siya, not for acute attack, and it takes time to work, hindi siya agad-agad. Mga 2 to 4 weeks before symptoms improve. Here are common cromolyn preparations in the Philippines. Compared to Montelukast, cromolyn is less commonly available, but these are the usual forms you may encounter. Merong cromolyn for allergic rhinitis. Meron ding cromolyn as eye allergies for allergic conjunctivitis. May cromolyn for asthma, but this is usually wala na dito sa Philippines. Meron siguro pero very limited lang sa Philippines. Parang very obsolete na siya because it's often replaced by your inhaled corticosteroids, yung budesonide natin, and Montelukast. Now, we look deeper sa ating leukotrienes. Kanina, we talk about mast cell releasing mediators. Ngayon, focus tayo sa isa sa pinaka-powerful and strongest mediators natin, yung leukotrienes. And leukotrienes, mas malakas pa sila kaysa sa histamine in causing airway narrowing. And aside from bronchoconstriction, they can cause airway edema, yung namamaga ang airway, mucus secretion, maraming plema, ciliary beat inhibition, hawak nila yung beat, hindi nalilinis ang airway, recruitment of other inflammatory cells, lalo pang dumadami ang inflammation. So your leukotriene don't just constrict, they sustain and worsen inflammation. So saan galing yung leukotrienes? So they are not preformed. Hindi sila dati andun na. Hindi sila nakastore. Ginagawa sila on demand. Kapag may stimulus, either mechanical, chemical, or physical stimulus, yan, na-activate ang inflammatory pathway. So, leukotrienes are produced via your 5-lipoxygenase pathway. So, itong pathway na ito, nakita natin to sa ibang mga diagrams, but we use the diagram na bagong nilagay ng ating RAW book. So, yung 5-LO pathway natin. So, 5-LO pathway, leukotriene production yon. So, merong stimulus, again, either mechanical, physical, or chemical. That one activates your phospholipase A2. Anong ginagawa niya? Yung phospholipids natin, kino-convert niya to arachidonic acid. So, nakita na natin to. And arachidonic acid splits into the COX pathway and the lipooxygenase pathway. So, COX pathway, ang pinoproduce niya dito is your prostaglandins. Sa 5-LO pathway, ang pinoproduce niya your leukotrienes. And we are targeting this side. Itong sa leukotrienes natin. And ito yung ini-stop natin for your hindi muna. Pero yan yung ini-stop nung isa sa ating mga drugs for anti-leukotriene agents. So, yan. Yung leukotrienes kasi natin, they binds to your, sabi natin, cis-LT1 receptor ng pinakita natin kanina, your smooth muscles, your blood vessels, yung glands natin. So, kapag nag-bind yung leukotriene sa mga cis-LT receptors, yan, doon na nangyayari yung mga bronchoconstriction, mucus production, and vascular permeability and airway edema. O, ba't bumalik ito? Yan. Now, how do we block yung leukotrienes? So, meron tayong dalawa, di ba? Yung first is, meron tayong 5-lipooxygenase inhibitor, which is your xyleuton. So, it blocks this leukotriene formation from the start. So, inhibition natin at this part. So, no leukotriene production at all. Then, meron tayong mga leukotriene receptor antagonists, meaning meron na tayong leukotrienes, andyan na yung mga leukotrienes natin, pero i-block natin yung pagkapit niya sa receptors. So, leukotriene is there pero hindi siya maka-block. Anti-leukotriene agents din natin ang monoclonal antibodies because this targets the deeper inflammatory pathways like your IgE and eosinophils. Siyempre, gamitin natin tong drug flashcard na to. Let's look at xylitol, which is your 5-LO inhibitor. So, instead of blocking receptors like Montelukast, it blocks the enzyme itself. So, pinipigilan niya yung paggawa pa lang ng leukotrienes. So, yung arachidonic acid natin cannot be converted into leukotriene. Meaning, pag walang leukotriene, walang or lesser yung inflammation. Parang sinara mo yung factory, walang lalabas na product, walang lalabas na leukotriene. Use of this one is for asthma prophylaxis. Long-term control siya, hindi rin siya biglaan. So, hindi rin siya for acute asthma attacks. Dosage nito, it's given 4 times a day. 600 milligrams 4 times a day. Medyo hassle ito kasi frequent ang dosing. I-compare nyo sa Montelukast na given lang siya once daily, kaya mas ginagamit siya. Common side effects of this one, headache, abdominal pain, dyspepsia, and weakness. Pero again, ano yung pinaka-important natin dito? You need to monitor for liver, hepatotoxicity. Ito yung pinaka-concern dito. Also, your xylitol increases levels of your theophylline and warfarin. So, ingat, baka ma-overdose yung ibang drugs. So, kailangan mong i-check kung anong ibang mga gamot na tinitake ng patient if you're given xylitol. Ang natin dito. Yan. ZZ0 like leukotrienes. Xylitol, 0 leukotriene. Yan. These are the xylitol products. Makikita nyo siya, tablet form siya. Oral drug. But you cannot see this in the Philippines na. Kasi mas ginagamit yung Montelukast or other controller drugs. Rare siya. Rare. Very rare. Ayan, tingnan naman natin si Zafir-Lucas. Si Zafir-Lucas, instead of stopping mast cells, binablock niya yung effect ng leukotrienes. Meron ng leukotrienes. So, it just antagonize your leukotriene receptor. It binds to the cis-LT1 receptor. So, no receptor activation, no leukotriene effect. So, kahit may leukotrienes, wala silang pupuntahan. Zafir-Lucas and Montelukast are both receptor antagonists. So, kakaiba si ating xylitol. So, Zafir-Lucas, zinazap niya yung receptor. So, Zafir-Lucas, pagdating sa ating dosage, 10 milligrams twice a day. Si 20 milligrams twice a day din siya for 12 years and above. Important dito to note is you should not give it on empty stomach. It should be given 1 hour before or 2 hours after meals. So, it's given as prophylactic only and chronic asthma control. It's also useful sa mga exercise-induced asthma, aspirin-induced asthma. Again, it's not for acute attack. Yan. Common side effects nito, headache, infection, nausea, diarrhea, abdominal pain. Generally mild but kailangan pa ring i-monitor. Yan. This is well absorbed sa katawan natin orally. Yung half-life niya is around 10 hours and it's metabolized in the liver kasi it's highly protein bound. That's why we also check for liver enzyme elevation. These are the common Zafir-Lucas in the Philippines. Yung brand nga natin, yung Accolade. it's less commonly used in the Philippines compared to Montelukast. Because, bakit? Nakita nyo kanina from the drug flashcard natin, it's taken twice daily, either below 12 or 12 years and above. And it must be taken on empty stomach. Meron din siya mga drug interaction. So, in practice, mas practical tayo, mas preferred si Montelukast. At andito na tayo sa twin ni Zafir Lucas, which is your Montelukast. Same mechanism but mas commonly used nga siya. Again, ang mechanism nila is they block yung ating cis-LT1. So, magiging useless yung mga leukotrienes na present na. And, same class sila with Zafir Lucas, but it is more commonly used kasi mas maganda yung or mas convenient yung kanyang dosing. Yan, makikita ninyo. Once a day lang sila, QD. So, for adults, 10 milligrams once daily. For children, meron tayong chewable. Meron din yung hindi chewable. Meron yung mga naka-powder form. And it's usually given at night. So, once daily lang. Very patient-friendly. It's used for chronic asthma control, pwede din for allergic rhinitis, pwede din for exercise-induced asthma. Pareho sila ni Zafir Lucas, that's absorbed orally and highly protein-bound and metabolized in the liver. So, makikita nyo, ang side effects nito ay diarrhea, laryngitis, pharyngitis, nausea, sinusitis, or viral infection. Generally mild, similar to placebo. So, pagbabalikan nyo yung inflammation diagram natin, your Montelukast works doon sa mismong receptors na ng ating smooth muscle ng glands tsaka nung ating vessels. So, it happens before airway constriction happens. Ayan. So, ito yung commonly used. Ito yung sinasabi ko sa inyong in powder form siya. 4 milligrams, makikita nyo. Yan yung hinahalo dun sa milk ni baby. Yan yung Montijet. Meron din yung naka-tablet form, pero ang pinagawa sa amin dito, this year, is didikdikin mo siya, and then ilalagay mo pa rin siya sa milk ng baby. So, very convenient and safe, kaya siya very commonly prescribed. Okay, so where do these anti-leukotrienes fit in asthma management? So, sabi natin, anti-leukotrienes are used as protection for triggers and for chronic persistent asthma. So, again, hindi sila rescue drugs, controller drugs sila for prevention ng inflammation. And very important role yan sa ating trigger-specific asthma for exercise-induced, aspirin-induced, allergen-induced asthma. Ginagamit siya. Example, the patient with exercise asthma, you give the Montelukast before exercise so that lesser ang bronchospasm niya. So, it is for protection. For chronic or persistent asthma, pwede siyang gamitin for those with mild to moderate persistent asthma. Pwede siyang gamitin as alternative or add-on. Especially if yung patient natin cannot tolerate steroids o ayaw niya ng inhaler because these are given orally. In relation to your steroids naman, steroids are still the gold standard or yung para sa ating mga inflammation. But anti-leukotrienes can reduce yung steroid dose natin and can prevent dose escalation. Remember yung ating slide ng chubby na babae. Ang dami niyang side effects. So, yun yung pinaka gusto nating pigilan. So, it reduces yung steroid dose and can prevent dose escalation. Especially, makikita nyo yung mga anti-leukotrienes natin. Very minimal yung kanyang mga side effects or tolerable. But your anti-leukotrienes, hindi siya effective alone. Kailangan combined siya with inhaled corticosteroids para pag combined, as usual, better yung control natin. Yes. Important lang dito, meron tayong tinatawag na Churg-Strauss syndrome. This is vasculitis, and it usually appears when yung steroids natin, tinetaper natin. So, akala nila minsan it's caused by your anti-leukotriene drugs, yung mga Montelukast, ganun. Kasi pinapakita niya yung totoong nangyayari. So, sa ating book, sinasabi, ina-unmask niya yung totoong nangyayari. Your Churg-Strauss syndrome is actually a rare autoimmune vasculitis. So, ibig sabihin, dito, inflamed yung mga blood vessels. This is how it looks like sa mga bata o mga tao kapag pinull out or in-stop na yung ating steroids. So, it's because of an abnormal immune response. It is associated with yung asthma plus eosinophilia. Meron tayo dito. Veg breakfast, vasculitis, eosinophilia, granuloma, bronchial asthma. That is your Churg-Strauss syndrome. And again, it's not because your anti-leukotriene drugs directly cause it. They unmask it when steroids are taken off or tapered or reduced. This is a hidden disease na lumalabas lang. Ito same na lang din, no? Dun sa sinabi kanina for controller drugs in persistent asthma, alternative sa inhaled corticosteroids like your cromolyn-like agents, not optimal as prophylactic as monotherapy. Dapat kasama siya with your ICS. May add-on benefit siya, add-on therapy, meaning kasama ng inhaled corticosteroids. So, instead of increasing steroids, we add leukotriene blockers. And, yan, safe siya and well-tolerated, which makes them a good option for long-term use. You have this in your book, itong ating box for advantages and disadvantages of your anti-leukotriene drug therapy. So, we just summarize it here. Bakit kailan sila magandang gamitin at kailan hindi. Advantages muna tayo. Why we like these drugs? Unahin natin, bakit ginagamit? Easy to use. So, it's easy to use. Walang inhaler technique. Very convenient, especially for kids. It's given once a day. So, some can be taken once daily like your Montelukast. So, this gives or entices better compliance, better control. Safe, nakita natin kanina, very safe with few lang na side effects na tolerable, kaya good siya for long-term use. It's also very effective sa specific asthma types like your exercise-induced asthma and aspirin-induced asthma. And in terms of systemic effect, unlike inhalers, these drugs reach the entire lung through circulation. So, kahit deeper areas, naaabot siya. And meron tayong additive effect with steroids. They work well with inhaled corticosteroids. So, they are not competing but they are complementing. And yung kanyang steroid-sparing effect. They can reduce steroid dose or prevent increasing steroid dose. And of course, yan, approved siya for children. May mga chewable forms pa. Very practical. Ano naman ang mga disadvantages? Kasi kanina, puro advantages ng anti-leukotriene drug therapy yung tinitingnan natin. Limited ang mechanism niya. It only blocks one pathway. Unlike your steroids. Yung steroids nyo, ano yon? Tatlo yung binablock niya. Tatlo yung effect niya. So, ito, sa leukotrienes lang, not the whole inflammation. Yes, compared to your steroids na broader yung action niya. Also, Unknown ang long-term toxicity, hindi pa fully known ang long-term effects. I think hindi rin naman kailangan tingnan kasi for like si baby, after 1 week, tinanggal na rin yung Montelukast niya. Variable response, sabi dito, hindi lahat ng patients nagre-respond. Only about 50 to 70% of patients, so trial and error minsan. Minsan feeling ko ganun ginagawa ng doctors. Trial and error sila. Kasi hindi rin naman nila alam talaga yung exact mechanism. Mas maganda na rin mag-try. No predictor or of response. Walang way to predict who will respond. So, sino ang yung babies ba? Yung matanda ba? So, clinical monitoring here is important. Systemic exposure, ito yung pinaka nakikita kong disadvantage niya kasi it's given orally. Unlike inhaled drugs na localized, they affect the whole body. So, meaning, there are possible systemic effects. And lastly, it's not useful as monotherapy. So, hindi siya effective alone. You cannot rely on leukotrienes alone in moderate to severe asthma. So, we are moving to the most advanced therapy in asthma, yung ating monoclonal antibodies, which is targeted and precision ang medicine na to. These drugs are used for severe asthma, so hindi na ito mild or moderate, pang difficult na to control asthma na. So nakalagay dito yung tatlo natin, omalizumab, benralizumab, tsaka yung dupilumab. Iba-iba yung mechanisms ng mga to, but lahat sila antibodies. They are not inhaled, mga antibodies to, they are given via injection or infusion. So, expect na mas mahal ito and more specialized yung use. So, the nature of this drug, they are DNA-derived human IgG antibodies, meaning engineered sila to target specific molecules. Yan. So, yung omalizumab natin dito, it prevents IgE from attaching to mast cells. Ito yung pinaka-example natin. No IgE binding, meaning no mast cell activation, less ang inflammation. Yung ating anti-interleukin 5 drugs, like your benralizumab, mepolizumab, at saka reslizumab, they are targeting eosinophilic asthma. So, they block yung interleukin 5 to reduce eosinophils. Yung ating dipulimab, which blocks interleukin 4 and interleukin 13, these are key cytokines in inflammation. So, all these antibodies, monoclonal antibodies, are given parenterally nga. So, again, hindi sila inhaled and not oral. Natin it's not given as monotherapy. Same concept, it's best used with other drugs. So, ang major benefit dito, they can be given to reduce steroid dose. They can prevent steroid escalation and reduce need for rescue meds. So, ultimate memory trick natin dito, biologics, itong mga to, big guns for severe asthma. So, if the inhalers fail, if your oral meds fail, we go biologic. Yan, these are the common monoclonal antibodies for asthma in the Philippines. And, of course, we only see this in tertiary hospitals or specialized hospitals for asthma. Kasi advanced asthma therapist nga to. Hindi ito first line, pero ginagamit ito pag severe na yung asthma na hindi na niya makontrol. So, another checkpoint number 5, which drug inhibits 5-lipoxygenase, thereby preventing leukotriene production? Checkpoint 6, a patient is prescribed a drug that prevents mast cell degranulation before inflammation begins. Which drug is this? Checkpoint number 7, which drugs act by blocking leukotriene receptors, such as your cis-LT1? Checkpoint 8, which drug works most upstream by blocking the IgE and preventing mast cell activation? Checkpoint 9, a patient with asthma on leukotriene modifiers develops vasculitis, eosinophilia, and worsening respiratory symptoms after steroid tapering. What condition is most likely? Checkpoint 10, which drug requires liver function monitoring due to risk of hepatotoxicity? Okay, so after learning the drugs, the mechanism, and the uses, the next question is, as respiratory therapists or clinicians, what should you monitor? So we have before treatment, yan, we first evaluate the patient for the most appropriate delivery formulation. So hindi lahat ng pasyente pare-pareho. Some can use MDI, some need nebulizer, some children need spacer or reservoir. Yan. And kaya kailangan i-check natin yung technique nila. For during treatment, yan, tingnan natin if the patient really know how to use the device correctly. For example, MDI timing, proper inhalation technique, proper nebulizer use. So assessment is not just the drug, it is also the technique. For we know that this is a controller, not rescue. So one of the most important counseling points ninyo as artists that these drugs are given as controllers. So kapag sabihin niyo sa kanila kapag may bronchoconstriction na or in acute distress, hindi ito yung drugs na ibibigay mo to give immediate relief. Then the use of peak flow meter. We also teach the patient how to use a peak flow meter kasi it will monitor the asthma control over time. Dapat lahat na may asthma merong peak flow meter, no? Pero I don't see this sa mami ko, nagkaroon siya ng asthma. Long-term, now for long-term monitoring, we don't just ask if the patient feels okay. We assess the full picture. So, tingnan natin kung nagkakaroon ba ng symptoms. Tsaka, how severe are the symptoms? Yung cough niya, yung wheezing niya, yung night awakenings, and shortness of breath. Meron pa bang mga exacerbations? How frequent yung attack niya? Gaano kadami yung kanyang ER visits? Yan. I-check din natin long-term pulmonary function, syempre. Then, we assess also the side effects of the drugs given to them. Nakita naman natin kanina, like cromolyn, may cough, may throat irritation, si xylitol, liver toxicity, mga ganon. As general contraindication or patient education, in general, alam natin that these nonsteroidal anti-asthma drugs are safe, but each patient responds differently. So, most important counseling point natin dito lang is it's a controller. Hindi tayo kasi tayo minsan sa Philippines pang ano lang, yung mismong rescue drug na pag may sakit na, hindi natin tinitingnan yung for prevention and for control. So, this is a quick recap. Before we end, we met cromolyn, leukotrienes, and biologics, and what do they have in common? So, they are not for rescue, not to save the day. They are here to prevent yung ating disaster. Control lang. So, remember, reliever, pang emergency, controller, pang long term. If the patient is already wheezing, too late na sila na ibigay. But if used correctly, they keep the airway calm, quiet, and drama-free. So, less inflammation, less stress, and hopefully less asthma attacks. That's all for Module 12. See you again for Modules 13 and Module 15. Bye, everyone!